Welcome back to the Dr. Doug Show. Today, we are going down this pathway of interviewing practitioners who are masters in the realm of hormone therapy. Today, I interview Dr. Terri DeNeui. Dr. DeNeui is a longtime practitioner in the space of hormone replacement therapy, works with both men and women, and is a big advocate for pellet therapy. Now, if you've heard me talk about pellets in the past, you know that my experience is that I have found that women have not done well, in my experience, on hormone therapy with pellets. So this is a fun conversation because she's a big advocate for pellets, uses pellets primarily in her practice. And so we get to go back and forth about her experience and my experience. And I think it's a really nice, open, easy conversation about the topic. But what's really important here is we dig into our younger patient population. We talk about perimenopause. We talk about when women could consider starting hormone replacement therapy and what kind of hormone replacement therapy. And I think Terri does a great job of breaking this down. And I really think that any woman who is concerned about her hormones, whether it be perimenopause or postmenopause, any woman who's concerned about her hormones, this is a great conversation with an expert in the space who has helped thousands and thousands of people to optimize their hormones. So take a listen to this interview with Dr. Terri DeNeui. Dr. Terri DeNeui, thank you so much for joining me on the Dr. Doug Show. We have a lot of things to talk about.
I'm so excited. Thank you for having me.
So I gave a little intro for those that are listening to this, but why don't you just give a little bit more about your background and how you got to where you are now, which is really, I consider you a thought leader in the space of hormones and especially pellet therapy. So how did you get here?
Yeah. Wow. So really, in a nutshell, I started learning about hormones about 15 years ago, really just kind of by happenstance, but I don't really believe in accidents, so it really wasn't. But once I started learning, and I started a small practice in the Dallas-Fort Worth area, but I was also simultaneously, while I had my clinic, working in hospitalists and emergency medicine. And the more I learned about preventative wellness, of which hormones are a huge cornerstone, I'm sure we'll get into that part of the conversation, the less I could continue to just be on the prescription writing wheel of what I was doing. I didn't feel like I was really helping patients in the hospital. In the emergency room, yes, you have broken legs, you have things like that, you can stabilize people. But from a chronic disease perspective, really pretty much everything we were seeing from a chronic disease perspective in the emergency room and as a hospitalist was all preventable. And so that really has kind of gnawed at me for a long time. So I eventually continued my education and learning more about integrative solutions and expanding the hormone conversation. And my practice just grew, and I was able to get out of the hospital. And now, we see about 1,000 hormone patients a month, primarily hormone pellets. And I just launched a book last year. I speak all over the country now at different conferences and medical conferences, and just educating practitioners because so many people want to get into this hormone space, especially pellets. And there's a lot to it. It's not just a matter, we don't really learn this stuff in our primary clinical training, as you know, and even for me, and even a lot of OB-GYNs that I work with and faculty that I teach with that are gynecologists, they'll be the first to tell you, we're supposed to be the hormone experts, and we don't really know a whole lot about hormones because, the extent of the education is someday your woman's going to have hot flashes and you can give her some Perimen, it's kind of like, that's about it. So that's what got me here, and it's just, it has been a journey. It's been a lot of fun, and now, our focus is how can we train more clinicians to really understand the art and science of hormone optimization.
Oh, that's beautiful, and not to downplay it. So your book is called Hormone Havoc, right? And that's available. How do people find that?
Oh, Amazon is the best way to find it. But I really break down, my goal with that book, it's not a book about pellets at all. I don't even know if I mentioned the modalities, maybe a little bit in the end, but really the goal with the book was dispelling myths around hormones in men and women. There's a lot of misunderstanding. There's a lot of bad information. They cause cancer, they cause heart attacks, they cause stroke, all of this bad information that's come out. So I really break that down chapter by chapter by each hormone. And then I get into a lot of gut and nutritional impacts of hormones there towards the end.
Yeah, beautiful. And so I wrote a book recently too called The Top 10 Reasons Why Your Hormones Are Failing You. And it's kind of the same idea. And I think there probably can't be enough books written on this topic.
Not at all.
Yeah. So
especially
it's amazing.
evidence-based books, not opinion. There's a lot of opinion books out there. You
Yeah.
know,
I
that have,
broke our editor's rules on the number of citations I could
yeah,
include.
same. Same. I have a couple of hundred. Yeah, that's great.
Yeah. Yeah. They were like, your book is half citations. I said, well, it's important. I don't know. So in your clinical practice, then you said 1,000 patients a month.
Yeah, well, not just me. I have
Clearly.
other practitioners. Yeah, but yeah, that's kind of really pretty much what we're known for is hormone optimization. And then
Yeah.
we do have a couple of our practitioners that pick up a little bit more and go a little deeper on an integrative functional approach. A lot of patients are when they're ready to get off all the medicines and all the stuff they're on. There's just so many ways we can get a lot of that polypharmacy out the door.
Yeah. No, I love that. What would you say on average if you were to describe your average patient from an age perspective? Are you guys really leaning more perimenopausal, postmenopausal? Where's your sweet spot? Where do you have one?
Yeah, I would probably say for females, so just breaking down, for males, we're about 70-30 female to male. So we do have a lot of males in our population. In
Yeah.
our female population, it's probably about the same 70-30, 60-40 of postmenopausal versus peri or pre. So I would
Okay.
say about a little more than half are postmenopausal. But interesting, more and more and more, we're seeing so much younger people, younger patients, younger men, younger women.
Yeah.
That's a whole other podcast. It has everything to do with our lifestyles and diets and epigenetics,
Absolutely.
like that. But yeah, it's a little more
Yeah.
than 50-50.
Well, and that's a fun podcast to do. And I think too, just the conversation around perimenopause and what symptoms may be hormone related is becoming more common. Like people are understanding, especially women are understanding, oh, this thing that I'm feeling, this depression, this apathy, like all of these things could potentially be hormonally related. And maybe I should seek out a hormone expert, not just go to my OBGYN, which isn't necessarily trained in hormone optimization, especially in perimenopausal women. So let's start there then, because from a bone health perspective, I was just at a conference and we were talking about, when should women screen? When should we be looking at bone loss? And my answer was, literally in your early 20s, right? But let's pretend that flatlines, bone loss flatlines for about maybe 20 years, if we're lucky. But then it starts to drop. And it really starts to drop around mid-30s, mid-40s. And I think a lot of that has to do with hormone fluctuations, especially in women who have dysfunctional ovulation, dysfunctional luteal cycles. So how do you approach the perimenopausal woman? If we could just start there, and I know that's a really broad question, but how do you start
Well,
there?
I think the biggest, the first thing to kind of understand is women, we start losing testosterone 50% per year in our 30s, and it's such a bone builder if we're just talking about bone. But it also,
Yeah.
my doctoral work was on depression and androgens, and there are thousands of receptors in the area of our brain responsible for mood and thinking and mental clarity for testosterone. And so this happens really young, and women that are on birth control pills, that can even happen in their teens and 20s, right? So when you're on birth control pills and you're shutting down, I'm leading up to perimenopause, but I'm trying to make the
No,
point
it's good. It's great.
earlier, in the form of testosterone deficiency, and women after that second baby, something just happens, and I wonder sometimes if it's just nature going, listen, you've had two, we're good, let's kind of slow things down. But androgen decline is just exponentially greater after that second child. And this is where women will say, I don't know what happened after that second baby. I can't get my, pre-baby body back. I don't have a libido. I'm moody. I'm depressed. I'm just not myself.
Yeah.
And then they get into their 40s. If they didn't get it addressed after that second baby, maybe sometime in their 30s, then they hit their 40s when progesterone precipitously declines. So first you have testosterone decline in your 30s, then you have progesterone in your 40s, and then you have estrogen in your 50s. So it's like this stair step down into, kind of the dungeon, that if it's not addressed, it can be a big deal. So what happens in our 40s is not only do we lose progesterone, which causes a lot of dysfunctional uterine bleeding and anxiety and depression and all kinds of symptoms, bone loss. Then in the perimenopause phase, it's not that we're losing estrogen as so much as we have huge estrogen swings. And so that's when menstrual cycles become spaced out in a woman who had had regular menstrual cycles previously. She might start having those moods, and that irritability ramps up a notch. And then hot flashes and things like that. And it's such a difficult time because most clinicians don't understand how to address hormones in the perimenopause time frame. They're just waiting on that magical day when you've been 12 months without a menstrual cycle, and now, yay, you're postmenopause, and we can start you on all the hormone therapies, right? So we manage a lot of perimenopause, and you can often get the majority of those symptoms very well under control with androgens and progesterone, if we're just talking about hormones. And then in the pellet world, there is a lovely, really low dose of estrogen pellet. It acts like a prandial dose, so it's not enough for a postmenopausal woman, but it's perfect for the perimenopausal woman because it just keeps that basal low estrogen so they don't feel those swings as much. So that's a really lovely option for people that have been trained that way, and not everybody's been trained that way. So.
Yeah, well, that's a beautiful way to describe it. I appreciate that, just all of that detail. I want to hit on a couple of things in there because I've learned the same thing, and as our practice has progressed into really working almost exclusively with people with osteoporosis, our population has gotten older.
Sure.
However, when we started, our population was actually pretty young. I think our average patient was probably 30s, and it was maybe 50-50 female, male. That's obviously changed now. And one of the things I had to learn very early on was how do we deal with the progesterone starting to fall, androgen deficiency. When I wrote my book, the first draft of my book, it was probably 80% on androgens.
Yeah.
Because there was just so much to talk about, and it's so underrepresented in the discussion. And then I backed off a little bit and changed a few things around, and now there's just one big long chapter on androgens.
Well, just to make a point about that is, and people always ask, once we get, and you've experienced this, I'm sure as well, you get a patient in, you talk about here's your deficiencies, and in those pre and perimenopausal women, it's primarily androgens. And then the question is always, why didn't my doctor know about this? I've been, complaining about these things every year. Well, that's a simple answer. There is no FDA-approved drug that pharma is representing.
What are they going to do?
Yeah, exactly. So they wouldn't know what to do because there is no FDA-approved medication, primarily because you have to have, for it to be a synthetic, it has to be a synthetic oral typically, and synthetic oral testosterones were taken off the market because they tend to metabolize more down a carcinogenic, a cancer-causing estrogen metabolite pathway. And so breast cancers were going up in women that were on those synthetic testosterones. So that's primarily the reason why, as you know.
Yeah, I didn't know that history. Yeah, I started utilizing androgens and specifically testosterone for women, and just saw great results, especially on our early women. And I'll circle back to that later with postmenopausal women, because I do find that changes. But then I wanted to hit on the progesterone side. So for women that are still cycling, is your preference to treat in a cyclic manner for women who are still cycling, or do you do kind of a low, kind of like you said with estrogen, a low dose steady state, or are you trying to really optimize their luteal phase?
It depends on the patient and the primary pain point she's complaining about. If she is complaining about the typical 40 to 45-year-old woman who is complaining of menstrual cycles so heavy and clotty they can't get out of the house without 3 super tampons an hour. Sorry to be so graphic, but there's no other way to talk about it.
For women that struggle, this is not new to them.
Sorry. But, that woman is so progesterone deficient and her cycles are so heavy and she's not sleeping at all in the night that I would put her on a lower dose, but every night, because it lightens those cycles. And then either if PMS is a problem, we may go up the week before her period, right? And then if it's just simply, heavy menstrual cycles, it just depends on the symptoms. Sometimes we'll do day 14 through 21, but by and large, the average 40-something-year-old woman that is having dysfunctional uterine bleeding does very well with a low-dose oral at night, because that oral compounded bioidentical progesterone has a great sleepy side effect, as you know. Double free sleeping pill. And so women love that, and they don't want to just get good sleep 2 weeks out of the month.
Right.
So how can we find? So that's kind of how we approach it, very individualized.
Yeah, and I love that you just finished with that statement, because that's what we've learned too, is that there's no SOP for
Right.
progesterone. There's no SOP for testosterone, and I want to get into that next
Yep.
with the training that you do.
Right.
But I totally had that experience where we used to use kind of low dose throughout the month, and we had good success, but not with everyone. And then we started switching more and more to cyclic as we were doing that in our postmenopausal women. And then, we got that complaint, but hey, it helps me sleep days 1 through 14, right?
Yeah,
And I'm like,
that's right.
well,
Yeah.
okay. So yeah, there's so much to learn, and this is why you can't just go to somebody who, maybe an OBGYN or endocrinologist, but if they haven't done really training in hormone optimization, there's so much nuance to hormone therapy.
Yeah, and it's the rare endocrinologist that'll prescribe testosterone to a female as well. So, it's sex hormones is a whole different conversation.
Yeah. Well, I'm glad we brought that up. I want to get into pellets because my audience, if people have been listening to me for a while, they've probably heard me on previous podcasts not talk bad about pellets, but just share my experience, which is I have a biased experience. I have a telehealth practice. Yep. And when women are coming to me, it's generally because they are not getting what they need somewhere else. So I totally understand that bias, and I want to make sure that my audience understands that too. But I hear from my patient population that haven't had a good experience with pellets that it could be any number of things. But the biggest thing I see is that women have had very high levels of testosterone and then have side effects. And of course, you can't get the pellet out. So Tell me a little bit about why you sort of went down the pellet pathway. And then what are some of I don't want to get into all the nuance because I know there's a lot, but what are some of the big things that you teach providers to look out for or to do when it comes to pellets? How do you make them safe and as side effect free as possible?
I love this question because you're right. There is, my husband, has a quote that he's said several times. The difference between medicine and poison is the dose, right? And so even something as innocent as testosterone, yes, you can have side effects. They're nuisance side effects. They're reversible, right? But they're still not fun. And so one of the things that I've noticed in clinicians, and it's one of the reasons why I was so passionate about starting my own education and training company in 2018, because the ones that were out there were simply just really training clinicians to, here's how you dose it, and they might have some dosing algorithm or something that they can plug numbers into. But no one was teaching them, well, what if my patient comes back and doesn't feel well? And a lot of practitioners just keep jacking up the testosterone, trying to chase something that might not be because of the testosterone. It could be they are nutrient deplete in some nutrient that is impacting their testosterone receptors, right? It could be that they haven't had their DHEA levels checked. It could be that their gut, it could be they're not metabolizing their hormones correctly. So there's so many nuances as to why a patient could still be having some symptomatology. And you have to have a clinician that will not only take the time to peel back those onion layers with you, but also really look for other causes. Because if your serum testosterone, free testosterone, this is another thing, a lot of clinicians don't look at free testosterone, and a woman can have a high total testosterone, but a low free testosterone. So free is really the magic number because that's what's available to your cells to do the work. Right. And so if a male or female, but females are the ones who have the most side effects. If a female has a really good free testosterone and she's still complaining of maybe libido, maybe not sleeping, maybe energy, you got to look for something else because it's not testosterone. And going up and up and up and up is only just going to cause side effects. So yeah, I do see. And then now there's this trend in a lot of clinicians that have been training on pellets to go all the way to the other side of the spectrum and start doing really low and having these low thresholds. And then the patients that felt better on a higher level are getting left behind, right? So it's just the fact that so many clinicians want this recipe that everyone fits into. Yeah. And it just doesn't work that way, especially with women and hormones. We're just all different. We're like snowflakes. We have variations, and we're not going to fit in that box.
I'll speak for the men too here.
Yeah.
As a man, I've been on testosterone and I've used all different forms. And I've treated probably not as many as you for sure, but I will say that men even require quite a bit of nuance to understand what's going on with them too. So not to leave men out in the cold. I tend
Sure,
to do
they
that a lot.
do. It's a little bit less than women, but yes, they
But
definitely do as
yeah,
well.
but you're right. There is so much nuance. You have to have such great communication pathways with your patients. And like you said about your clinic, you need to have an off ramp into some kind of a functional, integrative,
That's
deep
right.
dive type of capacity.
Yep.
Because you can't just go off of numbers, but you also can't just go off of symptoms. I
Yeah.
think you need the combination of the two. And I'm glad you brought up free testosterone because I see this all the time. People love just sending me their labs, which is
Yeah.
fun. Um, and there's never a free testosterone
Ever.
ever.
Well,
And
I didn't train that way, so I wasn't trained that way either. And so when I started another training company years ago, we didn't train thousands of clinicians that way too. So I think the education has evolved, and unfortunately, there's a lot of training platforms that haven't
right,
evolved, and that's
right.
why we're not seeing that.
Yeah, well, it also wasn't that available, and it was much more expensive, so it drove up cost. I mean, I get it.
Yeah.
But the way that I built our program, it was sort of like, cost be damned, let's do it the way it needs to be
Yeah.
done, and then we'll figure it out on the back end, which is not a good entrepreneurial move, just for the record. But
Done that.
it's all about patient care. But no, but
I
what
know my,
I've
my
noticed.
husband used to call me Florence Nightingale. He's like, you got to pay the bills. Like,
That's right. That's right. Well, and I do, my team too. Like now I don't actually sit in the finance seat and my team will say, look, you can't do that.
yeah.
That's why I'm not allowed to do sales calls because I
Yeah.
would just give it away. I want people to have it.
Yeah.
But yeah, the free testosterone thing is so interesting because I think in men it's a little bit more predictable, especially when you measure SHBG. You can kind of predict what free is going to be. In women, it seems so wildly unpredictable, even if you have SHBG, because you can have women that have total testosterone over 100 and their free is going to be less than 1.
Yeah.
And then I just had a woman this last week. I think her total was maybe 30, and her free was over 4.
Yeah.
I was like, I don't even know how you convert that much testosterone to
Well,
free.
the first thing that comes to mind to somebody like that is PCOS and other hormone abnormalities, but because that's what you would normally see in that. But yeah, it's the lab reference range, and our primary lab that we use is LabCorp, and the lab reference range for females for a free testosterone is 0.0 to 4.5, and so many people think that's the normal range, and
Sure.
I'm like, nothing is normal about 0. Let's
Right.
start there. So one of the things that I explain in my book too is that labs in the hormone world, in vitamins like vitamin D, B12, things like that, pretty much many lab reference ranges are basically the average of that lab's population. And so I always tell patients this is a population of a lot of, respectfully, sick, unhealthy Americans. And so if I am plotting myself out where I want to be on a bell curve average of a lot of sick, unhealthy people is on that right side of that bell
Yeah.
curve. So in the upper end of that reference range, because a lot of people say, well, I got it's the same thing for thyroid.
Oh, yeah.
Thyroid plays a huge role in everything we're talking about in bone. But free T3 is the primary hormone. So just because you're in the normal range, that doesn't mean you're optimal. Same thing with vitamin D. Optimal's over 60, but the range is 30 to 100. So that's kind of one thing that people have to kind of get away from, and clinicians too. I just hammer this in. I just was teaching a bunch of doctors at a big anti-aging conference this past week, and I just hammer it in. Labs are great for a baseline starting point and gives you some direction, but you're treating people, not paper. You have to get out of treating that piece of paper. It should be a guideline and nothing else.
Yeah, but I think you could also say it the other way around too, because there are lots of clinicians I think out there who are using hormones who refuse to do labs.
Yeah, there's
Right.
there's that spectrum, right?
And so I think you need both pieces of information to be able to say, oh, well, you're feeling this, your labs look like this, okay, this is the path forward. But without one or the other, I think you're really guessing.
Yeah, you're guessing a lot.
Yeah. So that's awesome. Let's move forward then to the postmenopausal woman. So let's say we are now, the magic 12 months has passed, the day has come, you are postmenopause. So how does that change what you like to do with pellets then?
Well, that's when we'll start layering in estrogen. And really, the studies show that the sooner you can start estrogen, like the better, especially in the brain. I'm very passionate about the neurological impact of estrogen specifically. All the hormones play a role in the brain, but estrogen is really important. And there's a great 2023 paper that came out that showed a woman just 3 years post menopause and the brain changes that happened with beta amyloid deposition, and the brain lit up. They had a baseline while she was in perimenopause and 3 years post-menopause, and you can see a huge area in the brain that lit up with beta amyloid deposition, which is the hallmark of Alzheimer's disease on an MRI, and she wasn't symptomatic yet. So the point is that there are changes happening in the body really soon, way before symptoms present. And so we've got to kind of unravel from this fear about estrogen. And obviously, a woman's biggest fear is breast cancer. I talk so much about breast cancer in the book, but I think that's what is still, a lot of clinicians that aren't up to date on the literature, that haven't seen the 2020 JAMA paper that says estrogen's the only drug that can prevent breast cancer and decrease all-cause mortality from breast cancer. Like, who nobody's seeing that.
What?
Yeah. It's not been posted on, the cover of Time magazine like it was in 2004, that hormones are bad and they're going to cause all these issues. So, we really got to unravel from this. So to answer your question, it's a quick move into estrogen. And most of my perimenopausal patients, I've already had them on a little whiff, so they didn't ever get too low anyway. But then we start going up very slowly, and the goal used to be just treat symptoms. I had an allopathic mindset, right? Give her enough to treat her symptoms, until I went through menopause and my body composition changed. And then I thought, all right, there's something to this estrogen and belly fat and body composition. And what I've realized now is if we can get our patients as close to those premenopausal levels of estrogen, everything works better. And they don't have bone loss, they don't have, the memory, the moods, all of those things. So now, does that mean that if the further out you are from menopause that you've lost your window? No, that's also old information. So.
Yeah, well, give me your thoughts on that. Well, gosh, I have so many follow-up questions to that. Let's just talk about it, since you just said the window. So because our patient population has gotten older, and we are routinely doing initial consultations with women in her 60s and 70s who had never been on HRT, right? That is the generation that got, let's just call it, screwed by the WHI.
Yeah, right,
so,
they did.
So we have an approach to that, and people have probably heard me talk about it. But what is your approach? 65-year-old woman, never been on HRT, and just I won't give you the secret, our secret. What is your approach?
It's obviously a start low, go slow, and this is, the further away they are from menopause, those hormone receptors haven't been hit in 10, 15 years, depending on their age.
Right.
It doesn't mean that they can't have it. It just means in our world, we like to wake those receptors up a little slower. If I go hitting a 65-year-old with the same amount of hormones as I hit a 52-year-old, we're going to have a problem. The 65-year-old might not be so happy with me initially, but I can get her there. It just takes a little bit longer, and that just mitigates side effects. Is anything bad going to happen to her? No, but she's not going to feel good a lot of times unless you do it slow. The side effects I don't like are, the breast tenderness, obviously bleeding. You don't want a 65-year-old postmenopausal bleeder in your office, So a lot of times, and especially if they're, even further out, like 70s, sometimes we'll even just start with androgens, because that's a nice little quiet wake up, maybe some progesterone. If they have a uterus, I'm a lot more cognizant of a slower, bring that in and wake up those receptors in the uterus a little bit slower. There's nothing more alarming for a 70-year-old woman to go to the bathroom one day and have stuff that hasn't been there in 20 years.
Yeah. Yeah. Well, so that brings up a great topic. So in my book, one of the reasons why I rewrote the entire thing is I got exposed to some of the literature on cycling progesterone. And it just caused me to go down this rabbit hole of education. And what I found is that actually in the bone health literature specifically, most of the protocols used some type of cyclic progesterone, and even some used, cycling up and down estrogen. I mean, really almost mimicking like physiologic restoration type of protocols. And so that was really compelling because the results from a bone perspective were always better in cyclic protocols. But then clinically, you have to then ask yourself the question, what are you actually going to do with these patients clinically? And I was just, like I said, I was just at a talk last weekend and I was kind of showing some of this data, and there was an OBGYN in the room and she was like, but won't that make them bleed? And I was like, well, this study? Yes, I guarantee you that these women were menstruating. They had to if they had a uterus, right?
Yeah.
Because their estrogen was rising and falling. They were reaching premenopausal levels of estradiol and then rising progesterone and then withdrawing progesterone. You have to be bleeding. There's no way you can't. So how do you deal with that then? Because you mentioned that you want to get to as close as possible to premenopausal estradiol levels. How do you deal with that in a pellet? Because I might be ignorant here, but the release from the pellet's going to be steady state, right?
Sure. Yeah. So the goal, and there is a magic formula that most people fall into successfully in the bell curve, but the goal is to have enough estrogen and progesterone. Estrogen is obviously trying to build a uterine lining, progesterone is keeping that in check. So the goal is to have a nice balance to where in our clinic none of our patients want to have a cycle, so we don't cycle. We want to have that sweet spot where their symptoms are free, they're getting all the hormones that they need for all the other brain, breast. I mean, progesterone, there's progesterone receptors in bone, the brain, the breast, the uterus, those are the primary systems. So I personally, my philosophy is the ovaries are the primary source of progesterone in a woman. So when the ovaries are done, her source is pretty much gone. You can get some androgen via DHEA from the adrenals a little bit. You can get a little bit of estrogen from that pathway also in conversion, but progesterone it's kind of like, where's the source of progesterone? It's just not there.
Yeah.
Yeah. So we approach those postmenopausal women with your ovaries were making all three premenopausally. We're going to replace all three, but it's that fine tuning that balance between estrogen and progesterone. So if you don't have a uterus, you don't bleed. Now, if she's had an ablation or a hysterectomy, I mean, yay! I'm so excited. I don't even have to worry about that. I can treat her clinically the way I want to treat her. But as far as like my way postmenopausal woman that hasn't ever had any hormones, we're going to get her there because I know how important estrogen is to that brain, and either we're starting out really, really low out of the gate, or we're stair-stepping in the hormones. Because if I just throw all three hormones and then some supplements and at a patient and that hasn't seen these hormones in 20 years and she has starting to have some sort of symptoms negatively, I won't know which thing it is. So It depends, sometimes I'm pretty conservative in just layering that in. But that's, again, the art of this conversation because nobody falls into that recipe, right?
Well, and let me just clarify one thing too, because I said all three, but so I'm assuming you would do estradiol and progesterone through the pellet.
Oh, no, sorry. Yeah, no. Estrogen and testosterone is through the pellet. Progesterone is always oral for two reasons.
Okay, gotcha. Yeah.
Well, primarily because it's standard of care and it's the only modality that has been shown in clinical studies to mitigate the stimulation of the uterine tissue. So I'm going to use what's been shown in clinical studies to prevent uterine cancer. There are progesterone pellets. We don't use them. Until it's evidence-based, I won't do it.
Yeah, I've never seen it personally that I know of, and that's why I asked, because I actually said it wrong, and I wanted to make sure everybody knew that.
That was a good clarity, because a lot of people just assume progesterone's in the pellet as well, but no, we use oral micronized compound progesterone.
Yeah, so then you can actually manipulate too the progesterone level as needed based off of symptoms. Do you have a serum level that you're aiming for, or is it not that specific for estradiol specifically?
Oh, for estradiol, it's more of an follicle stimulating hormone. So FSH postmenopausally under 20 is a premenopausal level. And so our goal is eventually under 20. Now, not the first time they get pellets, because she may come in with a FSH of 80. Well, if I drove that down to 20, that would take a lot of estrogen if I drove that down in 2 months, right? So it's kind of a gradual thing. But after 2 to 3 rounds, she should be gradually coming down to that premenopausal, 15 to 20, 10 to 20 range. Any much lower suppressed than that is probably getting a little over suppressed, but everybody's individual. So an FSH of 15 in one woman may correlate to an estrogen of 90, and another woman it be 120, and another woman it be 60, and they all feel great. So it's really hard to chase estradiol levels with pellets. It's not as clean. But the FSH, because that's for your audience, that's a feedback hormone. So the brain secretes follicle stimulating hormone in response to circulating estrogen levels. So when estrogen is low, the brain goes, "Come on, ovaries, get to work. I need you. Right. I need some estrogen." Right. But the brain doesn't know the ovaries are done working, right? So that's kind of the most accurate in my world, because it's a 2-month snapshot average. Now, it's not as accurate in other modalities, because you have these roller coaster, right? You do your cream, you take your pill, you put on your patch, you're up, then you're down within hours to days, whereas pellets last 4, 5, 6 months. So the FSH is a lot more accurate snapshot in the pellet world, if that makes sense.
Yeah, well, and I think too, so we've actually switched to using FSH as well, because when we first started getting into the hormone game, I looked hard and deep to try to find the literature that supported the estradiol level. And there is literature that will give you a range. And so we kind of say that range is 60 to 80 picogram per ml. And that's probably a fair target, but you have to follow the bone turnover markers, because we do see women at that range who it's not doing anything.
That's right.
And so we have to go higher. But then that's what we realized is like, oh, well, actually FSH tells us the answer, because we know that if it's impacting the brain adequately, then it's probably impacting other tissues as well.
Correct.
And so we see that correlation between FSH, bone turnover markers. And so we still look at estradiol, but it's almost more like, wow, where does it need to be? And in some women, it's lower than that 60 to 80, and in some women, it's much higher.
Absolutely.
Yeah.
Same thing.
That's really helpful. All right, so then you mentioned the timeline, and this is, if I were to make an argument for pellets, my argument would be convenience, 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 right? Because we have, we use creams and oral. We use creams for testosterone if we use it, estradiol if we use it, and then oral progesterone for the most part. And it's work. It is work, especially, the creams technically should be used twice a day.
Yeah.
Right? Like that's a lot of work. And so I could definitely see the convenience. But what are the other benefits that you think? I'm going to give you the platform just to say it. What are the other benefits of pellets?
As a clinician and a patient and other patients, it is definitely convenience is one of them, because so many patients are non-compliant with daily medications. So you can keep your patients compliant on your therapy. But what we've seen is that 24/7 level without the roller coaster. Long term, we see comparatively. Now, this is high level. There's not big head-to-head studies, and that's one thing that we are looking at comparing long-term bone, other biomarkers, hemoglobin A1Cs, CRPs, lipid parameters in the different modalities, because no one's compared the modalities with certain biomarkers and outcomes. But what we've seen clinically in our patient population is that we do see a much quicker recovery of bone loss because of the 24/7 presence of the hormone hitting the receptors in the bone. All 3 cells have receptors for all 3 hormones,
right,
for bone turnover. And then also looking at lipid parameters and hemoglobin A1Cs and body composition changes. And I don't know if that's because this is what needs to be studied, right? I don't know if it's because the bioavailability of the other modalities changes from patient to patient. Mm-hmm. I don't know if it's because the receptor site, one of the things we know is vitamin D is a powerful, you have to have good vitamin D levels over 60 for your hormone receptors, your androgen receptors to even turn on. So how many of my patients are compliant and have a high a vitamin D level over 60? So there's just so many variables with it. Yeah. But the biggest thing to answer your question specifically is the individualized approach. We do have the dosing pretty down now. That, and then the convenience, of course, and then having those hormones available in the body 24/7 is really key without big spikes. That's the other drawback of other modalities, especially we're talking about testosterone. My second favorite choice after pellets is rapid dissolve tablets, compounded, not troches. I don't love troches because they take too long. People end up chewing them and swallowing them.
Swallow them.
RDTs are great. It's a great modality because it's right to the bloodstream. But all these other modalities, whether it's a cream, an RDT, a shot, you're going to have a spike and a dump of hormone in the system. And that's not how I'm trying to get as close to hormone mimicry as possible. And our ovaries and our testicles don't surge a big dump of hormone in the system for the body to do something with. That's where a lot of side effects come from. That's where not all pellets are created equal comes from, because there's a lot of softer pellets and pellets that are compounded in such a way that they have a very quick spike and the side effect profiles are higher. So that's a key thing for people to understand, is not only is how's your clinician trained, but also where are they getting their pellets from, because that's very different as well.
Yeah. Well, there are so many things I want to talk about, but I know we're pushing our time. So I want to be sensitive to that. You just mentioned it. Not all pellets are created equal. So let's say somebody wants to go down the pathway. They're thinking, man, pellet is the way for me, and they don't necessarily live by you. So let's hit this into two things. So one is, where is your clinic and how do people become a patient? And then the second part of that, I'll ask you the second part of that when you're done. How's that sound?
Yeah, that's great. We are in the Texas area, Dallas-Fort Worth area, but our company trains clinicians all over the country. So we do have clinicians that are trained in our modalities, that have access to all of our functional integrative, trainings and forums, and we have a pretty robust platform for our physicians and our other clinicians to get the access that they need. So they come in for a 2-day training, and then they do refresher trainings annually. So anybody across the country could find one of our clinicians. Now, if they're doing what we teach them. So I always tell patients, when you're looking for a clinician, ask them, how many pellet procedures do you do a month? That's a very important question, because there are a lot, even that have trained in our network, that maybe only do 5, maybe 10, because their practice is busy with other things. You really, with pellets, because it's going into your body and going to stay there for a good 4 or 5 months, and they can't be removed, you really want somebody that knows what they're doing. So somebody that's doing 30, 40, 50 or more pellet procedures a month would be someone who's got enough experience and figured it out, or they've been trained and they understand how to do it, because that is a key factor.
Yeah, and you actually just answered the second part by saying that. So,
yeah.
All right, Terri, I think we'll leave it there. I have lots of questions I would love
We'll
to
have
ask
to have
you.
a follow-up.
Yeah, so we'll do a follow-up and we'll talk about the hard cases. And specifically for people that are wondering what that is, that's people that have a family history of breast cancer, people that have personal history.
I want to talk about breast cancer so bad.
Yeah, so we'll do a whole breast cancer thing, because there's a lot to talk about there. So anyway, thank you so much for your time. We'll end it here and we will set up part 2.
Sounds good. Thanks a lot. Thanks for having me.
Yeah, absolutely. So I hope you found that helpful. If you're looking for more information on hormones, please consider joining our Masterclass. We have a Masterclass that we run about every week or every other week with myself or a team member, and we go through some of the common myths and misconceptions around hormones and deliver some ideas of ways that you might be able to optimize your own hormones and deliver some potential pathways forward for you if you are needing them. If you want to register for that, look for the link in the description on YouTube, or you can head over to our webpage if you're listening to this on a podcast. The webpage is PEMA-bioidentical.com. That's PEMA bioidentical.com, or you can just look up what's wrong with my hormones.com, and that'll get you there too. All right, I'll see you in the next video.